I'm Dr. Michael Latola.
And I'm Megan Strong.
In this week's Case of the Week, the curse of the lower bicuspid strikes again.
And just when you think you should be avoiding that uncomfortable, prolonged eye contact with the patient in your chair, think again. It might save their life.
And just because you brand yourself as a dental spa, you're going to want to go ahead and leave the yoga to the pros. That and more on today's Chairside Live. Hey now, hello and welcome to episode 124 of Chairside Live. Megan, how you doing?
I'm doing well, and you sound like you've got a little frog in your throat, or what's going on?
I have a little frog in my throat. I've been home for the last 4 or 5 days with the flu, but I've been certified non-infectious by my cat. So I'm here today knowing that I won't get you sick.
All right, well, I just won't breathe for the next
yes, I'm sorry.
hour.
You and the viewers are going to have to put up with my Bill Clinton voice for the next 7 or 8 minutes, probably.
Okay, sounds good.
It's just a very lazy drawl. Very easy to do a Bill Clinton, as it turns out. Well, we've got a great show for you today. We've got some viewer mail. We've got some news, and we have an interesting case of the week. So let's go ahead and take a look at that now. Today's case of the week deals with a relatively common scenario, and I'm actually going to recruit you, the viewers, to help us out here. I have a solution that I had to deal with this, but I know there's got to be plenty of other ones too. So this is, again, a situation that's kind of particular most of the time. 80% of the time we see this, it's on lower bicuspids, just as this. So we've got a double arch impression that was taken for 2 BruxZir crowns next to each other. This on teeth number 20. And 21. And first of all, when you look at the impression, even though really what we're talking about here is undercuts, as you'll see, as I look at this impression and I hold it up to the light, and instead of holding it up to the light, I'm going to do the opposite. I'm going to take my iPhone 6 Plus. Yes, I know I needed to get the bigger screen. And as I look through here, usually we'd hold this up to the light and we want to make sure that the unprepared teeth are in occlusion. So we can see those two appear to be in occlusion. Of course, the preps won't be if they've been reduced enough. If we can see light through the impression of the preps, we got a real problem. But we don't see any occlusion on the first molar here, but we definitely see some on the second molar, but none on the first molar. Of course, there is an opposing tooth there for that first molar to bite with. So I have to question, when I take this out and this impression comes out of the patient's mouth when it's set, I look at it, and if I look at it and I see a first molar that doesn't show light through it like I think it should be, I will look again if I need to and look in the patient's mouth and see, is in fact, and maybe run some shim stock through it, is in fact that tooth not contacting the opposing tooth. That's really kind of the least of what we're talking about here, but when you look at the bite registration and see that lack of contact between the first molars, I say, is that really how this is? Now it looks like that tooth has maybe been ground on, that upper first molar, so perhaps that's the way the patient was actually biting down. But that's certainly something, and you can see maybe there's some contact with that second bite and that lower first molar, that you could see that little light showing through on the impression as well. So perhaps that's actually where it is. And if that's the correct bite, as if we look at the reduction from the scan and pull back a little on the zoom, we'll see that we have, in fact, on tooth number 21, 1.58 millimeters of reduction, which is enough for BruxZir. In fact, it's even enough for Emax, more than enough for Emax. It's ideal for BruxZir at 1.5, and it's great for Emax too. And if we look at tooth number 20, 1.57, so almost exactly the same, a tenth away from that, which is pretty amazing. That he got so close on both of those. Maybe he used a 1.5 millimeter depth cutter. I'm not sure. In fact, when you look at the margin here, it looks like he used that round burr that I like to use on my reverse prep technique. You kind of get the feeling on that one that you can definitely see that. Not so much on the tooth next to it, as we'll look in a minute, but it definitely looks like on that one. That's what my preps typically look like, using the round burr at the margin before I've blended all the axial depth cuts, for example. So the scan that's really most indicative of what's going on here is when we just isolate tooth number 21. And you can see, as we've scanned it here, everything that you see that is in red is an undercut. So there's even an undercut in the incisal third of the preparation, and certainly this mesial wall has a lot of undercut on it. There's certain things, like down in this area, this gray area here, where the scanner can actually see the margin along here, but then this margin all disappears, and this part of tooth number 21 is all out of view of the scanner as well. And so there's a big undercut, and this case is going to have to go back to the dentist for him to prepare a little more so that we can get a taper on here so we don't have all this part of the tooth in undercut. Interestingly enough, the deeper the gingival margin is here, the more likely we are to be able to block this out and still make a crown that will fit at the margin. And that's part of what's going on here, is that we have a deeper margin here. And so we'll be able to block this out, and we could get the margin here, but we lose it completely all the way along here. So let's take a look at the solid model and see what we can tell from looking at this preparation. And so I'll just turn it sideways. And again, it's going to be a little tough to see. I'll tell you what, let's look at the trimmed model so we can get a little better look at how the gingival margin looks. And so you can see that's what we saw in the scan too. On tooth number 21, it looks like the round burr was used. Not necessarily, but I'm just used to kind of seeing that on my own preparations. And maybe it was used there, maybe it wasn't used. And as we turned to look down, we were always taught that we should be able to close one eye and see all our margins at the same time. And you can see how, if I hold it just like this, that on tooth number 20, for example, we can't see that lingual margin. But as we turn it, now the lingual margin comes into view, and we can still see the buccal margin over here. Even though it looks to be kind of an undercut there, but we can block that out and still see that margin. Now, holding this and moving it around is so much easier in the lab, so much easier for a scanner than it is as a dentist trying to do this intraorally. And that's really almost kind of impossible. And you can see how long these preps are. And this is why it's these lower bicuspids where these things tend to happen. This is, like I said, 80% of the time, it's these lower bicuspids and sometimes upper bicuspids where we're going to have these types of undercut problems, because they tend to be on really long preparations. You know, typically we talk about a short preparation being 3 millimeters or less, and here we're looking at, as we look at this and hold the probe next to it, we've got, 3, 6, 9, a 9 millimeter long preparation, probably because of gingival recession. And a 9 millimeter long preparation is going to be very difficult to make it so it's not undercut. In fact, you almost have to over taper it, or you have to do additional occlusal reduction. The shorter a prep gets, the easier it is to visualize the amount of taper that's on a tooth. So according to the scan, if the bite is correct here, we have 1.5 millimeters. And I'm confident we could take off another millimeter, be at 2.5, and maybe be able to visualize the taper a little bit easier. I'm also wondering though, is that bite accurate? And maybe we don't have the 1.5 that we think we have. In my reverse preparation technique, I do a couple different things. I start with this round burr preparation in the gingival third, and it's the most shallow of the depth cuts that I do. And then we're going to do an occlusal or an incisal depth cut, but we also do an axial depth cut in the middle third. And that really is the depth cut. So it goes from shallowest depth cut to slightly deeper here to the deepest at the incisal or the occlusal. And then when we blend those depth cuts, it's really that axial one in the middle that's going to guarantee that we don't get undercuts. And so what if a dentist were just to do an occlusal or an incisal depth cut and use the round burr here? Well, it's pretty easy to end up with this type of result where you end up with an undercut. So, clinically here, when we don't have enough reduction, we can often just make the dentist a reduction coping, but you can probably see how difficult this is to make an axial reduction coping. So even if we come in here and we prep this tooth more along here and then make a reduction coping with a little window, it's really difficult to do. And right here on that mesiofacial is where we really get an undercut. We have to tip it way over to be able to see that margin, but then we lose the distal lingual at the same time. So it is a tooth that is under reduced. The way that I always do it, again, is with that axial third depth cut that comes in here right around the junction of the incisal third and the middle third. And by doing that, when I blend the depth cuts, by making that depth cut disappear that's placed right around here, I tend to get away from this. So I'm interested, and again, you can see with a deeper margin, like the one here or the one here on tooth number 20, that if we do in fact have an undercut here, we can block all of that out and still be able to see that margin, and that will allow us to get a good seal on the crown and you not have to get the patient back and necessarily do any more preparation. So my challenge for you is tell me your best way to avoid undercuts on teeth like this. You know, we were taught in school to go for 8 to 10 degrees of taper, but that's a very difficult thing to measure in the mouth. And I always joke that nobody makes an oral compass anyway, you know, like a protractor and a compass to go in there and hold it up and do it. Yes, I mean, you can kind of try to do it with a perio probe, but it's much easier to do, you know, out of the mouth where I take it. I'll try to tilt this so you can see it. Where I take it and hold it against this tooth, for example, on number 20, and then have to angle it in to touch in the gingival third. Now you can see that it's in an undercut situation, and then if I roll it back. So in the mouth, this is difficult to do with a burr or a perio probe. It's almost one of those things where you get the feeling that if the assistant, when she made the temporaries, would have let them sit on for 4 or 5 minutes, like Bisacryl temporaries, when she went to take them off, they might have snapped. It's hard to believe it came out clean, you know, here and here in these undercuts without getting stuck and breaking off. So maybe that's one way to do it, but I do it with the use of the depth cut, the axial reduction depth cut at the junction of the incisal third or the middle third to help me get away from these undercuts. I'm interested, what clinical tips do you have? What do you do in your practice to kind of avoid this situation, especially on lower bicuspids, especially on cases where there's been some gingival recession or periodontal disease? What do you do on these super long preparations to make sure you don't have undercuts? Because whereas we can make the crown on this tooth, doctor's going to have to re-prep and re-impress on this one for us to be able to make a crown. So I want to hear from you guys. What are your clinical tips on these long types of preparations for avoiding undercuts and having to get the patient back and re-anesthetize and re-prep? Please email them to us here at Chairside Live, and the winner will get some sort of nifty prize yet to be determined. All right, thanks you guys for your help.
Thank you for that, Dr. D.
Welcome.
Now let's go to a segment we call Viewer Mail. This week's viewer mail comes to us from Dr. Jamie Ryder, who writes in and says, "Dear Dr. Dottola, I really enjoy your videos and tips. I have a quick question for you." Well, that's good, Jamie, because that's the only kind we'll accept at this point.
Whoa, Jamie's crying.
No, she's all right.
Yeah,
He?
it's
She?
A he. Yeah,
it's a
pretty
he.
sure. I just wanted to throw in an old Van Halen
Sorry.
reference. Go ahead.
Oh, I totally
I know, you're too young for that.
over my head. Okay. In your videos, the patients are always so well retracted. Looks a lot easier to prep multiple teeth. What is the type and exact product of retractor you use for your large cases, such as crowns and veneers? Is this something you can order from Patterson, or is it a direct order product? And when doing large cases, like full arch, what type of temporary cement do you use to minimize cleanup and mess? Thank you, I really appreciate it.
Whoa, he snuck in a second question there at the end.
Yeah, quick.
Just when you thought it was going to be quick and just that one question. Oh,
Right.
by the way, parenthetically, almost a PS of sorts, but still in the body of the letter. Well, it's interesting that you asked that, and that is a question we get all the time because those retractors do work very well. And they're called the Seemore, S-E-E-M-O-R-E. Everything's a pun or a play on words today, like writer, and he writes in a letter for us. And now Seemore. Well, problem is they were from Discus Dental, and rumor has it they've been discontinued. Now, when that rumor first came out, we bought probably the last 1,000 pairs of those retractors. It just wasn't a big product for them. Most dentists aren't interested in working with retractors. I'm not sure why. Maybe they see it in the same category as rubber dam, but I guess I do see it in the same category. It's a great way to get the patient to shut the hell up. So I love putting in retractors, kind of like a rubber dam, because they makes it difficult for them to like stop or slow down the procedure. Rumor also had it, a second set of rumors, that Discus was going to start producing these again because, in fact, they had so many requests for them. So if Discus Dental is no longer making this Seemore retractor, the two that I would go to if I wasn't going to use those would, the first one would be the Comfort View from Premier Dental, and we'll have producer James throw a picture of that up on the screen so you can see what that looks like. That one probably provides the maximum amount of retraction, the closest to the Seemore retractor. The second one, which is more comfortable but probably provides less retraction, would be the Optergate from Ivoclar Vivadent. So it's definitely more comfortable than the Comfort View in some patients' mouths, just depending on their jaws really, and where they have certain prominences. But it doesn't provide quite the amount of retraction that the Comfort View does. So buy a couple of each and just experiment. Probably have both of them on hand anyway to see which one you're going to use. We probably lean more towards the Premier Dental ones, the Comfort Views, because we do so much photography and do so much filming. Second question that you snuck in there, and I'll go ahead and answer it. I have some reservations about it, but I'll go ahead and answer it. is about the temporary cement and what makes it easier, what cement we use on those larger cases. The cement that we use most of the time, and this is my assistant choosing this, she likes Next Temp from, again, from Premier Dental, or she'll use Temp Bond from Kerr. And I think that when it comes to easing cleanup, it has less to do with the particular cement that you use and more to do with what you do before you cement the temps and how you clean it up. So for example, on some of the clinical videos, you'll see that Jennifer, my assistant's going to place a large splinted Biotemps restoration into place, and she's got floss, like that Thornton bridge and implant floss, going through all the embrasures. She fills all the different abutments on the Biotemps with the cement and puts it into place. So as the temporary cement is seating, there's floss coming out from in between all those teeth so that you're never trying to get floss in between there and you're not able to clean it out. Because it's that bridge and implant floss, not only does it have the floss threader, but it's got that soft little caterpillar or pipe cleaner in there as well, which is fantastic for being able to grab onto pieces of temporary cement and get it out. So when you cement a full arch temporary bridge, for example, where all the teeth are splinted, if you don't have that floss in there, as you're cleaning it up, you're going in with an Explorer and trying to push it all out. And I do, in fact, find it easier, and so does my assistant, when she's already got that floss in place in all those embrasures as she seats the bridge. So I think that's probably the more important technique point here, rather than which particular cement that you want to use, because when you're cleaning up a splinted restoration like that, it's definitely more difficult than if those were all single unit crowns and you could floss between there with a knot and pull it through, and that's really the big issue. And if those Biotemps all were single teeth, they would start falling off as you tried to floss them, which is why most of them are made splinted together like that. And so try putting that floss in the embrasures right before seating it with the temporary cement on the inside, and I think you'll find that it does make cleanup a lot easier and make it go a lot faster as well. By the way, on smaller cases, you didn't ask this, but I think you were going to ask it next week, so I'll answer it now preemptively. On a single temporary where we've got a really short preparation where the temp bond or the next temp probably is not going to hold, we use Duralon, which back when I was in dental school was actually a permanent cement, a polycarboxylate cement. It hasn't changed at all. We just have much stronger cements today. So we'll use that for a long-term provisional if we want the temporary to be on for, say, 3 or 4 months. Or if we're doing a very short tooth with a short clinical crown, we'll put it on with Duralon. And the caveat here is make sure you have a sonic scaler of some sort. I use a Cabo sonic scaler to get that cement off the tooth. If you try to do it by hand with a hand scaler, you will be doing it for the better part of 3 or 4 hours trying to get the cement off the tooth. It always sticks to the tooth and not to the temporary, but it will keep just about any temporary from coming off if you need that over the Christmas break, for example, or if you're going to have it on for a long time while the patient has periosurgery or something like that, or you're working on the occlusion. So thanks so much for writing in, Jamie. Appreciate that. And you, as a result of that, are the proud winner of what, Megan?
Oh, well, how about this photograph?
And
so I have to bring it up with producer James because I believe he is the one that picks these photographs.
Right.
I'm not sure. I'm back and I'm not pregnant, so I'm not sure why we still have pregnant pictures.
Oh, I know the answer to that.
Why?
James has big mommy issues.
Oh.
Yeah, so for some reason he's really drawn to you as a mother.
That
or a
is
pre-mother. And also for Dr.
weird.
Ryder, we've got the BruxZir adjustment and polishing kit. So anytime you're working on solid zirconia, these are the burrs you want to use. This works very well for EMAX as well. These are very fine micron diamonds, a range between 5 microns and 40 microns. Theoretically, you should always use them with water, but if you don't use them with water, use them with just a very light touch with the air still turned on so you don't overheat the zirconia or the EMAX. All right, Megan, do you have any news?
I sure do. A California dentist was accused of using yoga as an excuse to touch a patient's buttocks and crotch in 2010. He admitted to lewd conduct but kept his state license. His probation ended early in summer 2013. Just 3 weeks after probation ended, a new dental assistant started working for the man. 3 days into her employment, the dentist offered to show her some yoga stretches and breathing exercise. He began to massage her inappropriately, and she went straight to the police. He pleaded guilty a year later to misdemeanor battery and lewd conduct. He surrendered his license in September 2014, 4 years after the first incident.
That's the first time I've heard the word buttocks used in quite a long time, maybe since 1950.
Well, I'm sorry, that's the appropriate thing to say.
I agree, it is the appropriate thing. And unfortunately, this is a really inappropriate story. And it's like, you know, the whole thing about yoga and bringing that into. Fortunately, I am so inflexible that I would never get myself into this situation, because I've tried yoga before at my gym, and it's one of the most difficult things ever. And it's one of those things where, maybe 20, 30 years ago, you could get away with this kind of thing. I mean, my private practice, the 8 women who I employed at the time, if you go back and look at it and you looked at videotapes from every day, they were kind of sexually harassing me. And that was just kind of, I mean, there really were, when you just saw like the inflatable dolls like in the employee restroom and stuff. It was all joking stuff, but it was the kind of stuff that today, if the wrong person got a hold, you just can't do stuff like this today. You just can't go into an office and offer to teach somebody yoga and start massaging somebody on the shoulders. It just doesn't fly today. And yeah, 40 years ago it might have been okay, but you can't do that today. You can't go out and have affairs today. You can't go out and kick over even a mailbox, because everybody's got an iPhone with a camera on it. We're being held to a much tighter standard than we were before. Which is good, but honestly, I never want to place blame on victims or whatever, because obviously you never know how conniving or whatever this really abuser this man was. But you'd think that the people, because it was not only an employee but also patients, you'd think that they would say, I'm at work or I'm at the dentist, why would this man be trying to teach me yoga? Right. And deny it and run away or whatever. Why is he trying to help me get into the lotus position halfway through my root canal? And it doesn't make sense. And I'm kind of glad that the second person went to, because it was a new employee, went to the police. Right. When it's easy to kind of look at it and go, oh wow, this seems like overreaction. But I get the feeling that it had to be pretty creepy, for something like that to happen, for someone to actually go to the police. So right, and I didn't go into that much detail. I told you that, as you so aptly pointed out, that I used the word buttocks, but he also was massaging this woman's breasts. Oh. Yeah. Now the yoga class that I went to, that didn't happen. I don't recall that being a part of yoga. Yeah. So she was obviously freaked out and violated. Right, okay. Yeah, I mean, this was not... So it was more than a shoulder touch. This was not just, Right. And I mean, in the beginning of the story, he was touching her in her private areas. So yeah, this is absolutely like abuse. Super creepy. Yeah. Okay, got it. All right. Yeah, that... buttocks alone is one thing. That's not right either. Yeah. But when you have all this other stuff in there, it makes it awful. Yes. All right, pick us back up again with our second story. All right, here we go. A routine dental cleaning may have saved an 11-year-old Oklahoma girl's life. During the procedure, the hygienist noticed that the girl's eye looked yellow. She called the dentist in to see, and he agreed. They told the mother, and she took her to the doctor. Turns out, the young girl had to have a 9-hour surgery to remove a grapefruit-sized tumor. Doctors removed part of her pancreas, stomach, gallbladder, and part of the intestine. The family is still waiting for test results to determine more about the tumor. Wow, that's amazing. So the hygienist looks like her, and she looks, I'm guessing, because I didn't see a picture, it looks like one of the extras in the Thriller video. Right. With like the yellow eyes like that. And says that doesn't look right, and so they send her to the hospital and they find the tumor. I love that it's 2015 and we're still comparing tumors to fruit, to common fruit, like grape. Well, what else are you going to use? Oh, I don't know, softballs or sporting things. Basketball, softball, baseball, golf ball, ping pong ball. But really bring some activity. But no, let's do it to delicious edible fruits. Like the size of a grapefruit or a pear. But congrats, man. Hats off. Hats off to them for being able to spot that. Hygienist, lifesaver. I mean, it's all in a day's work. It's kind of weird the mom didn't notice. Right. You think it was because maybe the overhead light as she was cleaning it, or because she had so long? I don't know. I mean, obviously, if the tumor was that severe and it was at that point, I'm assuming the yellow in the eyes was jaundice. Right. You would think that it had been going on for a while, and but maybe she just didn't notice. I mean, maybe. It is weird though. Like during a dental procedure or a cleaning, we have a lot of time to stare at the patient. Right. Like even when I'm giving an injection, I give injections really slowly not to hurt patients. And over the course of that 90 seconds, sometimes 2 minutes, depending on how sensitive the patient is, I don't have anything to look at. Right. I should be looking at their eyes and maybe doing a health screen. I'm checking out nose hairs and hairy moles, and that's just me. Disgusting. And I've never sent anybody to the hospital for a nose hair that was out of control. I've wanted to pluck it on my own, like just bring the handpiece with the drill
Right.
and hope it snags it and pulls it out.
That's so gross. But on the flip side of
with
that,
loops on, that's at 4X too. These nose hairs are huge.
That's so gross. But on the flip side of that, as a patient looking up at you, it's awkward because it's like, do I look at you? Do I just stare at the ceiling? Where am I going here? And there's no place to look, so you end up just making uncomfortable, prolonged eye contact.
Exactly. I'm staring at your nose right now. See, it carries over into regular life.
I don't have nose hairs though.
But I don't have my loops on. You're not. You're very clean.
Thanks.
One of the cleanest noses I've seen. But you're lacking that filtration device of all that hair. Wait till you get to be about 60 and a male.
No,
and
thanks.
You'll see what happens.
Well, I don't plan on that. So
that's good. Well, thank you for ending on a nice story about a dentist hopefully saving a patient's life just by looking at them and seeing that they didn't look well.
Yeah.
Awesome. Well, that about wraps it up for this edition of Chairside Live. On behalf of myself, Megan, the whole CSL crew, and everybody here at the lab, I want to thank you for your time and your continued commitment to quality dentistry.
We'll see you next time. A new dental assistant started working for the man. 3 days into her started over. And stop laughing when I say buttocks. Okay.
California dentist got all up in there.
Right.
Why is he trying to help me get into the lotus position halfway through my root canal?